Welcome to the Heart of Prevention, helping clinicians stay up to date on preventive cardiology. This show features leading experts discussing real-world strategies to prevent heart disease, from lifestyle changes like diet and exercise to medical treatments, including new therapies. Whether you're a medical student, resident, or practicing clinician, this podcast challenges, informs, and enhances your approach to cardiovascular disease prevention. The Heart of Prevention, keeping hearts healthy one episode at a time. I'm Dr. Michael Shapiro, President of the American Society for Preventive Cardiology, and now here's your host, Dr. Kirthana Pakanati.
Dr. Jawan, Dr. Jawar, Dr. Figueroa, welcome to the Heart of Prevention.
Hi,
Thank you,
Kirthana.
Hi.
So I'm Kirthana Pakanati. I'm a cardiology fellow and your host for this podcast. We're so excited to bring you a very special ACC wrap-up episode with 3 incredible trainees. But before we dive into discussing all things prevention from ACC 26, let me tell you a little bit about our guests for today's episode. Yara Jalwan is a second-year preventive cardiology fellow and ASPC cardiometabolic fellow at Johns Hopkins Ticcaroni Center for Cardiovascular Disease Prevention. I think I finally figured out how to pronounce that. And she just matched into cardiology fellowship at Case Western Reserve University Hospitals. Super excited for her. Nikita Jawar is a second-year cardiology fellow at Cooper University Hospital in New Jersey and recently got accepted to the ASPC Training Academy, so we'll be seeing her in Arizona. Super excited for you. And then Ivan Figueroa is a PGY2 internal medicine resident at the San Juan City Hospital in Puerto Rico, and you probably know him from running around conferences with his full studio setup in his backpack. I'm really excited to
Hi,
be with you
everyone.
guys today. Thank you all for joining me.
Thank you for having us.
So as you guys know, ACC is a very large conference. And if we were trying to talk about prevention, which played a big role in this year's conference, as you guys saw, we would have a 6-hour episode. So the purposes of today's episode, we're going to be focusing more on the late-breaking clinical trials. And while we do know that the lipid guidelines just came out last month, there'll be a separate episode discussing that. So we'll be kind of tabling that discussion. But we have lots of stuff to get into. And we're definitely excited to hear from everybody about these different trials. So Nikita, you want to start us off?
Sure. Thank you, Kirthana. And it's nice to see you, Yara and Ivan. Looking forward to our conversation today. The first study that I kind of want to talk about is the Vesalius trial. And this study really stood out to me because of how it challenges the way we think about cardiovascular prevention in the context of PCSK9 inhibitors. So we already know that lowering LDL cholesterol reduces cardiovascular risk, one of the most well-established modifiable risk factors that we have. And for years, we've seen impressive outcome data from other PCSK9 inhibitor trials like Fourier and Odyssey, but those were primarily done in the context of secondary prevention in patients who already had major cardiovascular events already. So the whole premise for the Vesalius trial was to see if evolocumab, a PCSK9 inhibitor, could improve cardiovascular outcomes in high-risk patients who had no prior ASCVD events. And this was a large double-blind trial involving just over 12,000 patients. The study included people who had established atherosclerosis without a prior cardiovascular event, cerebrovascular disease without a prior stroke, peripheral arterial disease, or high-risk diabetes, either requiring insulin or they had evidence of microvascular complications. And all those patients had an LDL cholesterol of at least 90 milligrams per deciliter, despite being on statin therapy. And some of those patients were also on ezetimibe. And they were followed for almost 5 years for dual primary endpoints. The first was a 3-point MACE, which included coronary artery disease-related death, myocardial infarction, or ischemic stroke. And the second was a 4-point MACE composite, which had all those 3 elements, but it also had ischemia-driven arterial revascularization. And so what they found was that for the 3-point MACE, evolocumab reduced the relative risk by about 25%, and it reduced the relative risk for the 4-point MACE by 19%, both with statistical significance. Along with this, they did a number of other secondary outcomes data analysis, which I won't get into, otherwise nobody else is going to have a chance to talk, but those were very, very encouraging data, which included fewer MIs and fewer ischemia-driven revascularization events. So I think the key takeaway here is that aggressive LDL lowering in select high-risk patients can meaningfully prevent a first first-time ASCVD event, and it really encourages us to rethink who we offer PCSK9 inhibitors to, particularly those patients with diabetes or subclinical atherosclerosis who still have persistently elevated LDL cholesterol. And of course, cost and access are real limitations in practice, but just from a clinical standpoint, the evidence suggests that intensive LDL lowering isn't just about immediate risk management after an ASCVD event has already happened, but instead it should be about trying to sustain primary prevention. And so with that, I'll turn it back to you, Kirtana.
Wow, that was an incredible summary. I feel like you really got me excited about PCSK9 inhibitors. And I mean, we've been seeing a lot of stuff in this area, but I loved the point that you made about this should change what patient population we're using it and how early we should think about it, right? Is this going to push PCSK9 inhibitors to be more towards the forefront if they're not already there for a lot of us? Does anyone else have any comments about this?
I'm so sorry that the Vesalius trial results missed the new dyslipidemia guidelines by so little, to be included in the guideline. But overall, that's a great study, that shows the role of the PCSK9 inhibitors in the primary prevention of these patients.
Yeah, that's a great point.
Yeah. Another comment I had, and we discussed the Vesalius in one of our meetings at Hopkins, and what I thought about was, is this really primary prevention when a lot of those patients had already established atherosclerosis? So can we really call it primary prevention? I think it's an important differentiation to make at this point. Is this like just secondary prevention, but before an event happens? Like, what do you guys think? I mean, I know we no longer think of things as black or white. We just see them as a spectrum. So is this just secondary, but right before something happens? Most of those patients did have plaque.
I think that it refers in terms of an event per se rather than the characterization of the patient itself. So I think that things of terminologies, I think, but I really can understand what your point is. Yeah, but we're really targeting patients where they already have some event or some risk, so I think that's like a mix up between primary and secondary prevention. So it's very
Yeah,
confusing and we have to establish it.
yeah,
Yeah, that's a good
exactly.
point. It wasn't like clearly defined as, I guess, but the assumption is that when we're talking about initiating these PCSK9 inhibitors, it's about pre any ASCVD event, and I think that's seemingly what qualifies as a primary prevention sort of trial as opposed to afterwards, but that's just my interpretation of it.
Yeah. Another comment I had about the Vesalius trial, because again, we discussed it, was what are you getting for your buck? Meaning, did we really, in this population, did we really exhaust all our possibilities? I mean, you can get ezetimibe, you can get a few other lipid-lowering therapies before jumping to PCSK9s, which we know are expensive. And so, have we really exhausted those options for those patients in this trial? If we were to choose between, like, if you had a patient who, for example, had all those risks, in addition had a BMI of 42, obstructive sleep apnea, etc., would you really choose the PCSK9 if you were able to choose something else, i.e. a GLP-1? Again, if you have the same amount of money, we're not talking about a trial where you have infinite amounts of money. We're talking about real life
Right.
here. And so is this really worth it? Like, was this LDL lowering worth it for this population, or would you consider other options or cheaper options, for example?
I think it comes down to generalizability. And we've realized now, especially talking to the attendings on the podcast, like everything is really personalized when it comes to prevention. It's all about meeting the patient where they are and making sure that whatever resources we're offering suit their particular clinical need. But that's a really good point to bring up that are we really going to pick this over something else? Or is this just something we tuck into our toolbox? Which honestly, the more tools we have in our toolbox, the better when it comes to this, because there are people that this will be a perfect fit for. And there are people that will eventually need this. So I think that's a great point. Um, Definitely a lot of discussion about this trial, though, and I'm excited to see what comes from this space as well. I mean, I definitely think it's been practice changing for a lot of us in like the general clinic side. And as we learn more, maybe it will lead to starting it earlier or getting ahead of it or finding that perfect patient that could really benefit from it. But great discussion about this first really interesting trial. We started with the bang and great summary. Okay, Yara, take it away.
All right. So let's talk about another really interesting study looking at triglycerides and coronary plaque. And so this trial was presented as a late-breaking trial. It was called The Effect of Intensive Triglyceride Lowering with Olezarsen on Progression of Coronary Atherosclerosis. And this was a sub-study on coronary CTA of the ASCENT-TIMI 73B trial. So let's step back for a second. We have believed for a very long time that triglycerides matter. They're associated with cardiovascular risk. They track with remnant cholesterol. And mechanistically, it makes sense, right? I mean, LDL is associated with increased plaque, so does triglycerides. It increases when you have obesity, it increases with bad diet, etc. But here's the key issue. We have never proven that lowering triglycerides actually changes plaque. And so this was a study that tried to answer this question. So what's olezarsen? Olezarsen is an ApoC3 inhibitor. It's a nucleic acid-based therapy that suppresses apolipoprotein C3. And it is potent, meaning it lowers triglycerides by 60%, lowers remnant cholesterol by 70%, lowers ApoB by roughly 15%, while LDL cholesterol stays unchanged. So this is very pure triglyceride-oriented. This was a randomized placebo-controlled CCTA sub-study of the ASCENT-TIMI 73B, as I said. They included patients who had triglycerides above 150, who had high cardiovascular risk, and importantly, who had non-calcified plaque on baseline CTA. They had 468 patients with paired scans, and they followed them up for 12 months. Okay? This is really important. Those patients were already on standard of care lipid-lowering therapy. So, primary endpoint was % change in non-calcified plaque volume. But let's look at baseline characteristics, and this is very important for me. Almost 97% of those patients were already on lipid-lowering therapy. And the average LDL was around 80 milligrams. Average LDL 80. So this was already a very well-treated population. Now, did the drug work? Of course. As expected, triglyceride dropped by about 64%, remnant cholesterol by 72%, ApoB by 16%, and LDL was unchanged. So, biology-wise, it's very effective. Lowered your triglycerides as expected. But did this translate into change in plaque? And the answer was no. And I think it's great, and I love seeing negative trials, really, because it shows first how much work we need, and then second, it's really important to have negative trials because this is science. I mean, not everything works, and so there was no difference between olezarsen and placebo in non-calcified plaque volume, which was the primary endpoint, or in the secondary endpoints, which included low attenuation plaque, total plaque volume, and other plaque characteristics. So despite this decrease in triglycerides, there was no effect on coronary atherosclerosis over 12 months. Now, how do we interpret this? First, there are a few limitations that the authors mentioned. Follow-up was only 12 months, so maybe if it was a longer trial, maybe we could have noticed change in plaque, maybe. Second, this was based on CCTA, in opposition to IVUS, which was used in other trials with PCSK9s, etc. So this was less invasive imaging, just a CTA. And third, and maybe most importantly, is what I mentioned earlier, those patients were very well treated. So plaque progression overall was minimal in both groups. And this highlights how much, I mean, it's not like we saw plaque progression in one of the groups and not in the other. Both groups, treated or untreated, had minimal plaque progression. And so this one puts things into perspective. I mean, the good thing is that those patients are well controlled. With their LDL well controlled, their plaques are basically stable. But also, it's very hard at this point to show benefit. And I think this is in the cardiometabolic space, it's getting harder and harder to show benefit when you have so many options, when you have statins, ezetimibe, etc. It's really hard to show benefit at this point. So yeah, bigger question: do triglycerides actually play a role in atherosclerosis progression, or are they just a marker? Are they just a consequence of other agents that act more on the plaque? So yeah, This was very interesting. What do you guys think?
I think that's a big a dilemma, in medicine because triglycerides value over 150 are part of the diagnosis of someone metabolic syndrome. So I think that with all these negative data regarding triglycerides, it can make us think of a great definition of what metabolic syndrome is, and proposing to quit the triglyceride levels from the definitions. That negative trials can drive us to new definitions in preventive medicine. That's my take on it.
Yeah, that's a really good point. I also just thought it was interesting, first of all, that they even did a triglyceride-centric trial because most of our guidelines and all of our efforts are really driven towards lowering that LDL cholesterol. So I like the novelty in the way they thought about this. And I also just thought it was so fascinating to see um, that they were trying to look at acute plaque changes, even, with triglyceride management. It's great to see how imaging can be used in this case. It almost makes the data feel a little bit more tangible in terms of disease progression, but completely agree with what you just said, Yvonne, that this is definitely something that will likely shift the paradigm of how we think about lipids in general.
I think so many good points were made even in the discussion. I mean, incredible summary, of course, Yara, but I love the point that you made that, negative trials show us just as much as positive trials. And also the fact that these patients were already on standard of care lipid lowering therapy, right? 97% of patients is probably more than our general population again. So it kind of brings up that point of generalizability for our patient population in particular, where some of us are just struggling to get our patients' LDL even down appropriately. I do think the point Nikita made about visualizing plaque, I mean, we know the power of that, right? We know that when we show our patients something on a screen that they can see, it really makes a difference in kind of helping them understand their overall health. So seeing the two together was definitely really interesting. But the point you made also about, the drug works exactly as it's expected. It did what we know it does. But does that actually translate to something clinically? And does that translate to something that matters? And so more questions in that space for sure. But I think it's always interesting to kind of see we know something works. Let's see how that actually pans out clinically and not just looking at the numbers here because the numbers alone would have shown us that it worked, but we're looking at plaque and really trying to understand clinically what that looks like. So definitely a lot of questions, but I appreciated your comment too about CCTAs versus a more invasive technique like IVIS to really fully visualize. Obviously, CCTAs are not invasive, so there's going to be a benefit to doing the testing that way. But definitely something that made me kind of think about how we visualize plaque also in the back of my head. So lots of things to think about, I think, with this trial.
Yeah. And it bridges to, again, I don't know about you guys. I think I've brought it up earlier with you, Kirthana, the Horizon trial, which we're expecting maybe in the coming year, which also like is about pilocarcin, I believe, that's we know lowers LP little a lot, but will it have an effect clinically? And so this is another, and again, the population is also very well treated in Horizon. So we'll see.
Yeah, that's true. More to come in that space for sure.
Yeah.
Well, now we're going to kind of shift gears a little bit back to talking about LDL. And Yvonne, take us away.
Yeah, hi everyone. So I want to highlight a trial that brought my attention. It was the easy pace trial. I found it very interesting because when we talk about this lipidemia, we always test for drugs, rather than compare them between placebos, so in this particular trial, we are comparing targets of LDL. They decided to compare the intensive targeting versus a conventional targeting of LDL. That means when you target less than 55 milligrams per deciliter versus less than 70 milligrams per deciliter, which is the conventional way. So I think that this is very interesting. It has a 2-year follow-up. So for me, that's a lot. That brings you a lot of data. 3,000 participants. It was just in South Korea. So in terms of generability, it can have that limitation that you cannot, compare that result with people around Africa, in America, in Latin America, but in terms of data and power, it got its purpose. So, you know, the results, and that was, when you get a target that is intensive, so less than 55 milligrams versus less than 70 that we're usually doing it, you have a relative reduction of MACE events by 33%. So for me, that's significant, in our population. We have a patient with a high or very high risk for MACE. So for me, that's an important topic in our practice, and the thing that makes this trial so credible is because, you have patients that looks alike in both groups, in both compared groups, and also they use to treat them as we treat our patients in our practice. Let's say that we always start with the statin, then we increase the statin dose until we reach goal. If not, we add ezetimibe, and finally we add the PCSK9 inhibitor. So, I think that's a trial that reflects what the actual practices are. So for me, these results can be very reproducible, and for me, that's a big issue, in our practice. So it targets a real picture of what our practice are, and it basically confirms that the lower the LDL, the better the outcome for our patients.
That last sentence, I feel like that's just it. I think that's such a great summary. And I think the part that I really appreciated was also your comments about, it's reproducible in our clinic. And the fact that on the safety side of the trial, we didn't see any increase in diabetes, right? Because we have patients that are coming in all the time that are like, am I going to get diabetes from a statin? Like, am I going to, have muscle related problems from a statin? And I think the fact that with this tighter control number that we were going for, this target, we didn't see any increase in diabetes or muscle related adverse effects. And I think that's huge, like, especially when we're talking to our patients, we can reassure them that just because we're going for this tighter control and we're, being a little bit more aggressive doesn't necessarily mean that that's going to put you at an increased risk for any of those safety concerns they bring to the table. What do you guys think?
Yeah, I agree. And to note, there are, I think, pitavastatin. I'm not sure if it is. I think it is available in the US. Pitavastatin is one of the statins that does not raise your A1C at all. And so typically when we have someone who's like pre-diabetic, at the edge, worried, this is what we would recommend. But yeah, I agree. Lower the better. That's where we're getting.
Yeah, I particularly like that this wasn't even about proving that getting an LDL to less than 55 works. We kind of know that now. It's more about showing that we need to be intentional and consistent and practical, thinking about cost-effective ways to get our patients on adequate and intense lipid lowering therapies. So just fits this idea that we've sort of touched on a couple times so far in this discussion today, but that earlier LDL cholesterol, excuse me, control gives more cumulative benefit over time.
Great. Well, we're about halfway through our trial, so I think we'll just switch it up a little bit and do a fun little break here with a little round of rapid fire. So the way that this works is I'll just ask you guys a question and feel free to kind of jump in with what your response would be. So my first one is going to be, what is one preventive myth that you guys wish would just disappear?
We get paid to prescribe statin.
That is a good one. That is a good one.
Yeah. I don't know what to answer.
Okay, well, here's another one. What is your favorite kind of exercise regimen or recommendation that you like to give your patients, or one that you guys enjoy yourself for heart health?
I think we constantly fight over cardio, meaning aerobic exercise versus strength training. And I think both are really important. And I think particularly cardio is extremely important. I do spinning a lot.
I think that a combination of both strength and cardio exercise, are the way to go. But we also have to encourage that, exercise is the way to go, even though you do, Pilates, running, all those things, just do exercise at least 3 times a week for 30 minutes each day. So,
Yeah,
Yeah,
just get up and move no matter what it is.
yeah.
I always end up citing the guidelines when I talk to my patients, and I've tried to change my mentality, so I have to kind of follow what I preach now. And so I've been really trying to fit those 150 minutes of real aerobic exercise. It's not easy, but I think for me, it's been a lot of running, biking, and of course some weight, like Yara was saying, of course, super important to do strength training as well. So I think it's all about balance.
Yeah, and
Awesome.
never underestimate the benefit from small efforts, like just taking the stairs, parking a little further just so you can walk a little more, taking a quick walk before lunch, going around the building, etc. Those like very small efforts. You don't have to sweat a lot to do a little more.
Yeah, or like not
Yeah,
ordering
I,
dessert. Yeah.
I have to apply that to myself.
I don't know if you guys have seen Dr. Osfeld during his presentations. He always has a slide that's like people taking the escalator at Vegas. And then this year at ACC, he had a picture of people taking the escalator at ACC. And I was like, wow, like, because everyone, and there was nobody on the stairs. And I think that is such
Were
a
there
great point of
stairs?
just,
I was one of those.
there were stairs in between the escalator.
I did not see stairs.
Yeah, I
I thought
definitely
I saw
didn't
you in
see
that
those.
picture
There
somewhere on
was
the
stairs
escalator.
on the conference.
Well, this was fun. I think, I love the point you guys made about let's just focus on a little bit of effort, a little bit of exercise. And then also the point about we don't get paid to prescribe statins is so huge because I think really, as we're building preventive cardiology as a field and we're learning more about what that really means to be a preventive cardiologist, there's so many things that we do. And starting with kind of misinformation and what patients kind of ask that is clearly not true is a great place to start. And with that, we'll turn back over to Yara for our next round.
So let's switch gears and talk about a very important study on coronary artery calcium, which is one of my favorites. The study was titled Reliability of CAC0 to Exclude Coronary Plaque in Diverse Global Cohorts. And this was from a group called the Global Probability Study of Coronary Artery Disease, or GPS-CAT. And so this was a very large international effort designed to study coronary artery disease around the globe. Motivation was most of our risk prediction tools were developed in Western populations, but we're increasingly realizing that those don't generalize well globally. In fact, the same group had previously shown that race, ethnicity, and country are independent determinants of coronary atherosclerosis, and they're only second to age, so they are a very important determinant. Now, why does this matter? We need to talk about CAC. So because CAC has been one of the most powerful tools we've had in prevention, we have studies, especially the work done in MESA, the work done by Dr. Nasir, Dr. Blaha, our lab, have shown us that the power of 0. And so a calcium score of 0 is usually associated with very low cardiovascular event rates. But there's a nuance. Even in MESA, there were signals that show that risk varies across ethnic groups. And more importantly, CAC only detects calcified plaque, which we know. We know that. But this is where CCTA comes in. And we've had trials like the Scott Hart trial, the PROMISE trial, that showed that coronary CTA can detect non-calcified plaque and may improve diagnosis and outcomes in select populations. So this sets up our problem. CAC is simple, cheap, powerful, reproducible, but it may miss disease, especially non-calcified plaque. And so this is what GPS CAD wanted to explore, but globally. So methods. This was a massive data set, over 32,000 patients across 15 countries and 22 populations. They all underwent simultaneously CAC and coronary CTA. And the endpoints were simple: CAC, 0, non-zero; CTA, plaque, no plaque. And they just built a 2x2 framework: true positive, true negative, false positive, false negative. False negative was our most important, or at least the point of this all. Now let's pause here a little bit, because this, I think, is very important. CAC is a screening tool and not a diagnostic tool. CAC typically is not done just to diagnose plaque. It's done to help in decisions when it comes to treatment, when it comes to aggressiveness in treatment, whether it's lipid lowering in kind of moderate risk patients. And so this study was not judging calcium score, but it wanted to see how does calcium score correlate with actual plaque across different populations. And so results overall, true positives were about 53%, true negatives about 38%, and false negatives were 7%. But the real story here was the variability. And so across countries, 4% in Uganda to 28% in Egypt. And true positives ranged from 21% in Uganda to 63% in the United States. So we really saw this variation even when adjusted to all the variables like age, etc. Even when adjusted, there was a huge variability between countries. And so the country itself was an independent predictor of a false negative calcium score. And so compared to the US, countries like Egypt had an 8 times higher odds ratio of having plaque despite a calcium score of 0. And so this pattern held also for race and ethnicity. And we all know with the Southeast Asian race, for example, the most recent studies that are showing that it is an independent factor and it's an independent risk factor for coronary atherosclerosis. But also, again, false negative rates ranged from about 6% in Hispanic, Latino, white populations to 21% in Middle Eastern populations. And this touches me at home because, again, we tend to generalize all those studies and etc. But it's not really it may not be generalizable. And so what is this really telling us? It's telling us that risk is not just biology, it's biology plus context. Where are you located? What's your risk? What's the population that you belong to? What's your race? And when you put this into context of prior studies, this adds a critical layer that the reliability of CAC0 is not universal, but also we need to focus on an important caveat, which is, again, this was the presence of plaque on CTA. Now, does this correlate with clinical events? Does this correlate with death? We don't know. Is this even, it's not even, like, because there were studies that showed, for example, the presence of obstructive plaque. Was this even obstructive plaque? We don't know. It was just plaque or no plaque. And so I don't think this eliminates the power of CAC0, not at all. But I think it makes us think a little bit more about risk in a different way. So we cannot overinterpret this study clinically. But the key takeaway is, as I said, a CAC score of 0 is not equally reassuring in all of our patients. We need to consider race, country, where they're coming from, etc. And so what do you guys think?
Yeah, I think you summarized that really well. It sounds like a CAC of 0 is powerful, but not perfect. And it would be interesting going forward to see if they do, more population-specific sub-studies or sub-analyses, because I think there's always a risk of undertreating or overtreating if we generalize some of these data. So like you said, some of those factors like family history and ethnicity, polygenic risk, things like that would definitely be important going forward. But I thought you did a really good job summarizing that.
Yeah, it was really impressive that it's like the second most after age. It's the second most important variable. It's crazy.
And the importance to sharing it to all the clinicians around the world, because if they got a calcium score of 0 in their patient, it's important for them to don't give up on their patient regarding screening of a plaque.
That's such a great point too, especially like education for kind of all the clinicians out there to know like everything has to be put into context, brings back that individualization that happens with prevention, and all of us can, you made a comment about South Asian cardiovascular risk and really understanding the nuances behind that. And like you brought up Middle Eastern. And I think that definitely kind of brings home to me as well and kind of cuts close to home and makes me think about like when my parents are talking about their risk, I'm like, yeah, okay, I know you read this, but let's talk about it in context to us or my aunts or my uncles or my cousins. Some of them are starting to reach the age where I'm like, okay, when's the last time y'all got your cholesterol checked? Because sometimes I feel like we make the worst patients. But that was a really great summary. And I think you really brought up some strong points that everything is personalized to the patient. So we definitely have to keep that in mind as we're talking to people in clinic, and not everything is black and white. I'm going to turn it over to Nikita now.
Sure, yes. And I'm excited to share another very interesting study called the Momentum Studies. It was unique and informative and centered on hypertension. And as we all know, hypertension is one of the most common conditions managed by cardiologists, but not all hypertension is created equal. Something that I learned at the late-breaking trials, which kind of stuck with me, was that up to 18% of patients with hypertension meet criteria specifically for resistant hypertension. And over the past several years, our knowledge of secondary contributors to resistant hypertension, things like hyperaldosteronism, have become increasingly well known, and we've become better at recognizing and treating those sort of contributors. Now, the Momentum study looked at endogenous hypercortisolism as a potential contributor to resistant hypertension. And it's actually the first observational multi-center study in the United States to investigate the presence and prevalence of endogenous hypercortisolism among adults with resistant hypertension. I feel like I'm saying resistant hypertension so many times. The investigators screened more than 1,000 patients who met criteria for resistant hypertension, and that by New York Heart Association definition, that's a systolic blood pressure greater than 130 millimeters of mercury, despite the use of 3 or more antihypertensive drugs at maximally tolerated doses, and one of those had to be a diuretic, or a blood pressure at any level while being on 4 different antihypertensives from all different classes. So this was a population with clearly challenging blood pressure control despite substantial therapies. And the study investigators used dexamethasone suppression testing to assess for endogenous hypercortisolism. And what they found was that 27% of patients with resistant hypertension had high endogenous cortisol, which is really eye-opening because this clearly represents an under-recognized contributor. And not just that, but of those people who were found to have high cortisol levels, they performed CT scans and they showed that about a quarter of them had adrenal nodules, which are potentially actionable. Right, in the right clinical context, surgical evaluation could be done, and resection could be potentially even curative, as opposed to escalating antihypertensive medications. So one of the major implications of this study is that resistant hypertension should prompt a more careful phenotyping approach, in the same way that we don't think of heart failure as a single uniform disease anymore, but instead we stratify patients into HFrEF and mid-range and HFpEF. We should be cautious in how we approach our patients with hypertension, and we shouldn't really treat them as one, distinct pathology. There might be distinct endocrinopathies or secondary factors that play a role. It also just underscores the importance of multidisciplinary care between cardiologists and primary care physicians, endocrinologists, to work cohesively, diagnose accurately, and then tailor therapies appropriately. But yeah, I think the broader message from this study was that resistant hypertension is not always just your run-of-the-mill hypertension, and sometimes requires some more investigation.
18% is definitely a number that sticks with me. That's higher than I thought it would be, but I guess,
Right?
it also sometimes in cardiology clinic, we're seeing patients on like one end of the spectrum or the other. And so there's this entire population that really, underscores the importance of the multidisciplinary approach because hypertension is managed by a lot of different people. And I think that's a great way to think about it. Do you guys have any other thoughts?
Yeah, I think that because of studies like this, that's why the new hypertension guidelines, highlight this workup for hyperaldosteronism. And from our standpoint, our internal medicine program, since the guidelines came in, we're testing a lot of our patients, and we're surprised of how many patients do have hyperaldosteronism. So.
Yeah, that's a great point.
That being said, did you guys ever see feel? Don't you like? I feel like in med school, I really thought I would see pheochromocytoma way
She's gonna
more.
ask if PHOs are a real diagnosis, isn't she?
I knew that. I knew someone was going to ask that.
I mean, I've never seen it. I really genuinely believed that I'm gonna see so many feels in my time as a doctor, but I haven't.
I did not during my endocrinology rotation, but I bet somebody that's listening on here has definitely diagnosed one.
Please let me know. Please
I
tell
hope
me
so.
it's real.
Well, that was a great summary. And as we're going to transition into a couple other trials that I'm going to kind of summarize that are very diet focused and kind of, we know that that's a big part of prevention. I thought I'd ask you guys one more little question that you guys can kind of mull over if you want. And maybe you can give me your answer at the end of one of the summaries. So I give you guys a little bit more time to think about it. But I just kind of wanted to ask you guys what your go to like heart healthy diet spiel or recommendation or even snack is for your patients. So you guys can be mulling that over as I kind of go into our next trial, which was the Go Fresh RX trial, simultaneously published in Nature while being presented at ACC 2026. This one was really interesting to me because the particular patient population that we deal with in the South Sound and Tacoma, Seattle area, kind of I was trying to think about how this would be used for our particular patient population, as we've talked about, right? Reproducibility of the results. This was basically a structured grocery home delivery program aligned with the DASH diet, which dietary approaches to stopping hypertension, along with dietitian counseling. And we saw that it significantly reduced systolic blood pressure and LDL-C among Black adults with hypertension, particularly those living in a food desert, compared with the grocery stipend and basic dietary guidance. And so it wasn't so much about just giving them a stipend, but really helping them educate what exactly they should be looking for. So this randomized 176 Black participants with treated hypertension. So treated hypertension, right? This is an adjunct to people that are already on medication. Everything kind of works together here. With a systolic blood pressure between 120 to 149, who lived in Boston communities with few grocery stores and low incomes, 1-to-1 to either a home delivered grocery program with personalized guidance from a dietitian or a monthly grocery stipend and a pamphlet, which we all know the pamphlets, we hand them out, we love them, but sometimes they are kind of a lot of information all at once, or they're very generic and they're not as applicable as someone sitting in front and obviously counseling and talking to you as a dietitian would. And this pamphlet explained kind of what's high in fruits, vegetables, whole grains, low fat dairy, nuts, seeds, legumes, etc. That Mediterranean diet that we know and love so well. And participants were around that 60 years age range, 80% being women. We love to see that. And the baseline systolic blood pressure and diastolic blood pressure were about 131 to 78. And at around a 3 month span, we saw an overall 7 millimeters of mercury reduction in systolic blood pressure in the grocery delivery group, but also a 2 millimeter reduction in that grocery stipend group too, right? And the home delivery group also had a greater reduction in the secondary endpoints of diastolic blood pressure and LDL-C. And these reductions persisted 3 months even after the intervention ended. Kind of the limitations when we think about this 3 months, right? When we think about habits and building those healthy habits, and dietary changes are hard, especially depending on what season we are in our lives. I definitely have patients. I have family members that are like, well, I don't want to check my LDL around this because so and so is getting married, or it's the holidays, or like, I'm just going to starve myself for 3 months and then I'm going to come back and do my blood work. And I think we have to remember that the study did have some limitations, but it had some really great stuff, right? A grocery home delivery program is kind of a godsend for patients that are in a food desert without a lot of options. And so it'd be interesting to kind of see, okay, how does this compare with people that have diabetes, or maybe their systolic blood pressures above 150, right? Those really difficult patients, maybe even the resistant hypertension patients from the earlier trials we were talking about. But I definitely think it's a step in the right direction. I think it's an incredible resource to even offer your patients. And I would love to kind of know y'all's thoughts on that trial.
I mean, it's seemingly simple, but so powerful to think about just the importance of education, access, and how we can work on that to better support our patients. And actually, as a plug to sort of answer your question that you asked us before, because I think it relates to this, is what I actually started telling my patients, and I kind of stole this from one of my mentors in residency, was apart from, again, just giving them the pamphlets, which I do, and I'm pretty sure, those are not utilized the way I intend. I told them that when they go to a grocery store, they should try and spend more time around the perimeter of the store, not in the middle, because that's usually where the
Oh,
fresh food and that's actually some of my patients have
That's a
given me
good one.
feedback that actually, wow, like I remembered that. And that tends to be a pattern at all grocery stores. But yeah, point
I
being
like
that,
that one. Okay, tucking that
yeah,
away.
yeah. But point being, yeah, I think this was a great study and a very different perspective taken. Um, Not just thinking about medicines, but what can we do at just basic level of providing access to heart healthy food.
So I think that the best diet that a patient can have is the one that he can gather in the grocery store. and the access to specific foods, that they have in their current countries, and based on their realities, and based on that we can apply some principles from all these studies. Eating more vegetables are more healthier for your patient. So there is no specific diet for a patient for me, because it has to be based on their own reality. Also, it can drive some public policies, regarding public health, and help access to the patient to food, but not only to food, but to education also.
Yeah, that's a great point. I also attended a session, just a side plug, but I went to the food is medicine session, which was really awesome. And Dr. Sperling mentioned something called medically tailored meals, which I have to admit I had never even heard of. But these are actually fully prepared meals that can be prescribed for patients, that are kind of, again, dietitian led. We love our dietitians. Prevention is very much a team sport, as we've talked about. But I thought that was really awesome. And I've definitely spent some time now back in my own town, kind of looking up like, okay, what kind of options do we have for medically tailored meals in my city? Because I just thought that was really interesting. But I think this is a great start for sure, in that we can really show that diet, as we know, is the baseline for everything for prevention. But I really think this was a really interesting trial with a lot to learn from it. And then we're going to shift over to another food as medicine trial, but this is the Thrive trial. And what I thought this was interesting was they mentioned that it was culturally aligned dietitian coaching. And before I even get into anything else, like as a first gen kid, I just think that is so incredible. I'm sure all of you guys will agree with me on this, right? Like, it's really hard when
100%.
you give a patient who is of a different ethnicity a piece of paper with meals that they would never eat to begin with. And I really loved that the dietitian coaching for this particular trial was aligned with the cultures of the patients that were right in front of them. And in particular, this was looking at Black and Hispanic adults with hypertension, and they had a food as medicine intervention as opposed to an equivalent amount of fresh produce without the additional supports. Again, same kind of thing, right? If you hand someone a pamphlet that says you should eat this much X, Y, and Z, and then the person's like, I don't even know how to cook this. I don't even know how this is eaten, right? Like, for some reason, Brussels sprouts came to mind when I thought of that. If those are not cooked well, they don't taste very good. But so this pilot study really randomized 80 adults with hypertension that were living in Maryland communities where it's difficult to obtain fresh produce, right? And so half were put into this prolonged intervention with culturally aligned dietitian coaching, an AI optimized feedback and encouragement, and then a flexible produce selection from a farm stand, which living in the Pacific Northwest, I feel like farm stands are very common, but maybe not as reproducible for other parts of the country. And then the other half received a standard weekly bag of produce with basic nutrition messages, right? Mean age of 55, two-thirds of the patients were Black, a third were Hispanic. At 24 weeks, they saw a significantly greater reduction in systolic blood pressure for patients in that intervention group, right? 6.8 millimeters of mercury on average, compared with 0.3 millimeters in the control group, which still got a standard weekly bag of produce, which quite honestly may not even be what some of our patients are able to get access to, right? We're already kind of starting a little bit above of what some of our patients are able to do. And the patients who adhered more strongly to the DASH diet had a 13.3 millimeter mercury reduction in systolic blood pressure. And this exceeds improvements with some hypertension medication, although we're recognizing here that everything has to be worked together. This is not at all a replacement at all, right? And I think what we have to remember here, right? We're looking at very specific demographics, we're looking at very specific subsects of people. And so in order to really illuminate how to make this a broader approach, we have to meet the patients where they're at. But that cultural relevant dietitian discussion was just so awesome to me, because I think so many people and patients of color and patients of other ethnicities get very intimidated by the handout because they're like, I don't need anything on here. And so I really loved that. And I think this trial is definitely a step in the right direction. And as we know, food is medicine, right? What do you guys think?
I agree
Yeah,
that food support should be treated like a true cardiometabolic therapy, and I'm so glad to hear that there is a shift in focus towards that. And I'm kind of bummed that I didn't get to attend these at ACC. Too many things going on at once, but I'm glad that you were able to share that with us.
yeah, and I really liked the fact that they were independent, like the patients were independently choosing their own. And so this, I think, was very important because, I mean, if you're just gonna hand it out to them and it doesn't fit what they typically eat, just like Brussels sprouts, So I feel like adjusting, and we as preventive cardiologists don't always have the time to do that. And so I typically ask my patients what they're eating, what's their diet, but I cannot go into the details of like what oils do they use, etc. And so I feel like the use of AI kind of helps manage this inability or this lack of time, at least, that we have, and it helps adjust, because you can teach the system what you want it to teach patients, basically.
Exactly. And I feel like that cultural integration is more likely to improve patient adherence in theory as well. So really like a win-win.
Yeah, definitely thinking about like my parents, my family. I feel like, so a lot of our parents are maybe heading towards that age or have reached that age where I'm like, man, now I know like a little too much. And now I'm like, oh, how do I? It's really hard to convince your parents to do one thing or the other. I don't know if you guys feel that way, but I love that we're kind of meeting patients where they're at in relation to that. So Nikita gave us her answer to her healthy habit approach for patients, but Yara, Ivan, do you guys have your answers to that of how you talk to patients about healthy habits and diet?
Yeah, definitely. For me, I try to, my main advice to patients is always to start with a vegetable. Start any meal you're having, start it with a vegetable. If it's a cucumber, if it's a little bit of radish, whatever vegetable seems appealing to you, try to start your meal with it. It would give you the fiber that you need. It would give you the water that you need. It would make you a little fuller before starting with all the other families of foods like carbs, proteins, etc. So yeah, that's mine.
Yeah, my healthy habit recommendation is to do exercises, at least 3 times a week. Always focus on a stepwise manner, for the patient, because if you gave them all the recommendation that we are summarizing, that can be so overwhelming for them. Also, just remember that this is an holistic pathway for, in order to improve someone's health. So the healthy habit has to be introduced in a stepwise manner. First, encourage eating, like Yara said, eating more vegetables, their favorites. Also, and do at least exercises to at least 3 times a week. It can be, while you are seeing any episode of your favorite Netflix series or anything like that, just make it entertainable for them.
I think that's a great point too, is we have to remember that like these habits, we want them to be lifelong. We don't want a quick and easy fix and something that they're going to do temporarily. So encouraging patients to kind of make those decisions on their own and get to there slowly is huge. I'm definitely going to steal some of these advice points, the grocery store, the eating the vegetable first. I was thinking about like when I eat, if I eat the vegetable first, and I think it depends on the vegetable, but
Definitely not Brussels sprouts.
yeah, ooh, sorry, Brussels sprouts getting a bad rep. If I could just learn how to cook them better, maybe it's a me problem.
They can't be good unless they're drenched in oil. Otherwise, they can't. I tried. I tried so many times. I have a story about this. So I once got a message from a patient. It said, like, the title was, "Your hummus recipe brought me luck." I'm like, oh. So I opened the message, and turns out when I saw this patient, he was asking about the Mediterranean diet. He's like, "What do you mean the Mediterranean diet? I eat a lot of hummus." I'm like, "Yeah, store-bought hummus is very high in calories. It's like it has all the seed oils. It's really not. You should be making your own hummus." And so I gave him a recipe, and just like a typical Lebanese recipe, that was like my contribution. I just told him, like, just chickpeas, lemon juice, a little bit of tahini, and that's it. And so apparently there was a medication that the insurance was not covering. And once I gave him this recipe, they covered it. And so always share recipes with your patients. They might get coverage if you have.
I need the recipe too.
Like, I want this recipe.
Me
That's
too.
really awesome. I love that. Well, we have one more trial that Yara is going to go over, but this discussion has been awesome so far. And I'm sure we will have lots of awesome other, presentations. We didn't even get into the moderated posters and everyone's incredible posters for the sake of time, but we have one more that we're going to talk about.
Yeah. So I'm going to jump back to hypertension, and I'm going to discuss the Cardinal trial. So it's a trial which looked at a completely different approach to treating hypertension. And so the drug that they wanted to study was tonlamarsen. I don't know if I'm pronouncing it correctly, tonlamarsen, which is a nucleic acid-based therapy. So it's an RNA targeting drug, and it suppresses the production of angiotensinogen in the liver. And so I'm going to take you back to biochemistry. Angiotensinogen is the very first step in your renin-angiotensin-aldosterone system. And so instead of blocking the pathway downstream like we do with ACE inhibitors, ARBs, this is shutting it down right at the source. And so this builds on a broader class of RNA-based therapies that we've seen in the cardiometabolic space, specifically, for example, inclisiran, which, as we know, is a small interfering RNA that targets PCSK9 production upstream in the liver to lower LDL cholesterol, in opposition to our known PCSK9 inhibitors. And so instead of blocking a protein after it's made, those therapies prevent the body from making the protein itself in the first place. And so conceptually, tonlamarsen is applying that same idea to blood pressure. If you suppress angiotensinogen, you should reduce just the RAS activity and lower blood pressure. And so this was a randomized placebo-controlled trial of about 485 patients with uncontrolled hypertension, all of them already on 2 to 5 antihypertensive medications. And so one key detail in the design of this trial is that all participants received an initial dose of tonlamarsen before randomization. And then half of them continued the monthly injections, the other half switched to placebo. And so from a biological standpoint, in terms of results, the drug worked, meaning angiotensinogen levels dropped by about 67% in the group that continued the therapy compared to 23% in the group that didn't, in the placebo group. But when we look at blood pressure, again, things got interesting. Systolic blood pressure dropped by about 6 to 7 millimeter mercury in both groups with no significant difference between them. And so, again, another negative trial, very important, we love those, but that was consistent across office measurements, home blood pressure, target achievement. So you end up with this very strong biological suppression of the pathway, but really no clinical benefit. And so the most likely explanation, since everyone did get an initial dose, that maybe the effect of the drug is long-lasting and even the placebo group may have had an ongoing angiotensin suppression. But it also raises a deeper question. Does it really add much beyond what we already have in terms of standard RAS blockade? Does it really add to our ACE and ARBs? So overall, Cardinal was one of those studies that raises more questions than answers. But it's really important step. It's an important step in understanding how far upstream you can go in targeting blood pressure. And more broadly, it reinforces the idea that even with these very precise RNA-based therapies, modifying a pathway does not really always translate into more clinical benefit. And so, yeah, I think it's exciting. We haven't had new blood pressure medications in a while, so it's really nice that they're studied and that we are looking for new agents. But yeah, another negative study.
It's kind of interesting that everyone got a dose before they got randomized because
Yeah.
it kind of seemed like a lot of their, results and the comments that were made were that that could have really affected the outcomes data. And so I thought that was an interesting choice. It makes a lot of sense clinically. We've been talking about that, right? Like these medications, they make sense in your head that they're going to work at a certain point because we've learned all this stuff deep in our memory somewhere from medical school. But I do wonder if that really is related to the reason that we didn't see that big difference is because everyone kind of had a little bit of it still in their system, for kind of lack of a better way of saying that.
Yeah, I was
Yeah.
wondering the same exact thing because they definitely demonstrated proof of mechanism, right? Angiotensinogen in some form, at least modestly lowered blood pressure in patients who were already on multi-drug regimens. But yeah, the timing was a question that I had as well. And the other thing that I also kind of think about going forward is as more studies are done on this, trying to develop or strengthen our antihypertensive agents, what threshold of blood pressure lowering is going to justify parenteral, presumably expensive therapies when many patients still aren't optimized on, triple oral therapy or fixed dose combination therapies as well. So just something that I was thinking about as you were sharing. Yeah.
Yeah, that's a great point. The more tools we get in the toolbox, we actually kind of have to think about the order in which we're going to do them and kind of what patient is going to benefit from what specific therapy. Wow, I learned a lot. Thank you guys for summarizing some of the trials I wasn't able to make because, as we've talked about, ACC is a little bit of a grind and there's lots of things happening at the same time. And I think we really, we covered a lot of those big late breaking clinical trials. There were so many other sessions and posters and moderated sessions that we heard and got to learn from as well. But this was really fun, you guys. I had a really great time talking with y'all and very excited to see everybody in Arizona in a few months at the ASPC conference. And thank you guys so much for taking the time to do this episode today.
Thank you,
you so
Kirtana, for
much.
this
Thank you for having
opportunity.
us.
Thank you so much for listening. To learn more about the ASPC, please visit our website at aspconline.org.